only mode.
Thank you everyone for joining us for another Learning Lunch hosted by formatapproved.com. My name is Brian Johnson. I'm the Senior Director of Online Training and Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch will cover how to keep up with Stage 2 of meaningful use. We are joined today by Joy Rios of formatapproved.com. Joy is an expert in meaningful use who brings both a comprehensive understanding of the objectives and other requirements of meaningful use, but also extensive real-world experience working with ambulatory providers to meet attestation requirements. Today she is going to guide us through the transition from Stage 1 to Stage 2 for eligible professionals. It's our pleasure to bring her expertise to you. We have a large audience for this webinar, and I know there will be many questions. Remember that you can ask questions of our presenter at any time by entering them into the chat area during the presentation. In the second half of our session, we will address as many questions as time allows. If we do run out of time, written answers to the questions will be posted to our website and sent via email link later in the week. Also, our guests often ask us for a copy of the slides. All registered attendees of today's session will receive an email with links to both the slides and the recorded version of this event. All right, Joy, well, thank you for joining us again. I think this is going to be a lively session.
Yeah, it's my pleasure. Thanks for having me.
So let's get right into it. What are the biggest changes from Stage 1 to Stage 2?
Well, the first thing to think about is actually the reporting period. And one thing I want to point out is that for the year 2013, nobody is reporting Stage 2. So as we go through this webinar, don't be thinking this is something that you have to be doing right now. Essentially, the early adopters who started reporting in 2011, they are going to be the ones that start reporting Stage 2, and they'll be doing that in 2014. And if you look at the requirements of Meaningful Use Stage 2, 2014 is a special year. So no matter what stage you're in, if you're in Stage 1 or Stage 2, you only have to report a 90-day period. So that's good news. One thing to think about, though, is that that 90-day period has to be aligned with a calendar year quarter, so January to March, etc. And for most providers, they're going to start reporting Stage 2 requirements in 2015 or beyond, and that will then they'll be required to report a full calendar year. So that's one big change. The second is Stage 2 is essentially intended to build on the objectives and measures set in Stage 1 of the EHR incentive program. So in Stage 1, we were looking at promoting the adoption and sharing of electronic health information. And Stage 2, we're looking to advance clinical processes. So this advance takes the form of higher thresholds rather than the introduction of more objectives. So what they've done is instead of, they've taken some of the menu objectives and added them to the core. They've looked at some of the core and decided that they were unnecessary and actually removed them. And then in addition to that, they've increased a lot of the thresholds. So providers are going to have to demonstrate a higher level of use of their EHR and show that they're consistently using certain kinds of applications such as the e-prescribing or communication among other providers and with patients, and also exchanging health information. So the health information is a big thing to keep in mind. And then in addition to that, it keeps going, there's, we've got to be thinking about structured data, making sure that the information that is exchanged is a way that can be read easily by other software systems. And then also engaging patients. So we're looking at patient portals. They're becoming more and more important because they foster patient engagement and allow you to share the health information with them. It's their record. And then lastly, clinical quality measures. That is one change. There's still a requirement. They're no longer a requirement as a core objective in Stage 2, but they have sort of changed the structure of what clinical quality measures need to be reported and specifically how they report. So in stage 2, they need to be reported in an electronic form. It can't be done just by paper.
And as a quick follow-up, that reduced reporting period for 2014 is partly reflects the the large shift involved in stage 2, but a lot of it has to do with vendors being able to be ready as well. That's my understanding.
Yeah, that's right. There's a lot of requirements of providers, but there's also specific additional requirements from the technology. So they're doing the 90 days in 2014 to allow everybody to catch up and get used to the changes in the requirements that need to be met.
All right, Joy, what are some of the specific changes to the objectives then?
Well, so for stage 1, there were 15 core objectives. Like I mentioned, they took some of those, and there were 10 menu objectives, which you could choose 5 from. So what they've done is they've taken some of those menu objectives and they've pushed them into core so that they're mandatory. So now there's a total of 17. And then for the menu objectives, they've reduced the number so that there's just 5 that you can choose from, and then you need to report on a total of 3. So what this means is that gives providers a little bit less flexibility when it comes to their reporting, but it still allows room for them to choose which objectives best suit the needs of an individual practice and a patient population. So one thing to think about is many of the new measures with new exclusions are optional for 2013. So it gives people an opportunity to get used to some of the changes in the objectives, but then they become required in 2014 and beyond. So as an example, there is an optional or alternative CPOE, the computerized provider order entry measure. In stage 1, that was based on the number of unique patients. So 30% of all medications had to be entered using the ePrescribe module through the computer, and it was the calculation of 30% was based on the number of patients. They've updated that so that in stage 2, not all patients get medication prescriptions. So now that 30% is based on the total number of medication orders. So it sounds to me like they're kind of redefining it in more specific and applicable ways for eligible providers. So in that instance, that's a good thing.
So let's talk about the threshold increases that providers need to keep in mind. You touched on that a little bit with CPOE, so let's continue down that road.
Sure. This is not an exhaustive list by all means, but this is an example of what you should be keeping an eye out for. So for CPOE stage 1, you had to input 30% of your medications in through the computer, and then or through the EHR. And stage 2, they increased that threshold to 60%, and then added on that 30% of your labs and 30% of your radiology orders need to be ordered through the computer as well. So that's something I'm going to touch on a little bit later, but we go into that. So the demographics, the information that you'll be collecting is still exactly the same. You're still looking at preferred language, ethnicity, race, the typical demographics that you should be used to by now, but they've increased the threshold from 50% of unique patients to 80%. Same with smoking status. And then clinical summaries. If a patient was asking for a copy of their visit or their encounter, in stage 1 you had 72 hours to give it to them, and in stage 2 it's just 1 business day. So there you go.
So it's taking a lot of the things that were going on in stage 1 and really ramping them up. I think under the assumption that by now you should have a lot of this figured out, and it's just advancing the implementation, I suppose.
I think so. I think essentially what they're trying to do is create habits, get people in the habit of doing things a certain way, and slowly having folks change their workflow and their method. And so just by increasing the numbers, they're increasing the likelihood that people will fall into these hopefully good habits.
So what do providers need to know about health information exchanges?
Well, health information exchange is a really big part of stage 2. In the first stage, you were just responsible for submitting data electronically through a registry. So often that meant that you checked with your EHR vendor and okay, do we have the capability and have we tested it? Can we submit? And you do it one time and that's all you are responsible for. And same with testing the capability to transfer patient records using the continuity of care documents. So it shouldn't be something that you should be familiar with, at least know that it exists within your EHR. But for stage 2, they've really amped up the requirements. And so that for 50% of patients that you're transferring to another setting, you need to provide a summary of care for those transitions. And then you must successfully exchange summaries of care with a provider using an EHR system from a different developer. So talk to your friends if that's the key part, is that using a different EHR. So it's not necessarily exchanging health information with somebody within your own practice or at a different location. You need to find somebody using a completely different EHR from a different EHR developer and exchange health information. So they're trying to get people to talk to each other more.
Well, I know we already have one question about HIE, so I'm sure that'll be a subject we'll return to later. Let's talk about patient engagement. I know that stage 2 really ramps up the patient engagement sphere of things.
Right. Well, this sort of touches on health information exchange as well. It's basically exchanging the health information and giving it to the patient. So in stage 1, there was no requirement. There was no need to get them involved. But in stage 2, it's required. You have to, eligible professionals need to offer electronic access to their health information for more than 50% of patients, and they need to be able to provide the ability for those patients to view online, download, or transmit their health information data, and they are also responsible for making sure that they engage with secure messaging, so HIPAA compliant, email or secure messaging either from within the EHR system or from within the portal, and in order to qualify and meet the requirements for stage 2 meaningful use, this is the part where 5% of those patients that you engage with, they need to have responded. So if you've provided 50% of your patients access to their health records so they can see it online, you need to be able to report that 5% of those folks have viewed it, downloaded it, or transferred it to another doctor. So it's interesting because the providers, they have to increase what they're doing. The technology now needs more functionality and capability, and now providers are also responsible for making sure that the patient responds to them and engages with them. So that's an interesting thing. One thing that I've noticed is that the HIE requirements, this whole thing is part of a larger push to get data into the hands of patients and expand the network of information that revolves around their use of the healthcare system. So, providers should investigate, launching a patient education campaign to let them know that patients have a portal that's available to them. Studies have shown that many patients who are given the ability to view their health information are thrilled with the chance, making them feel more empowered and aware of their daily lifestyle choices. I can attest to that. It is great knowing, with people that go to different doctors, they have different, pharmacies that they go to, or, essentially, actually, I wanted to talk about that later. Sorry.
We can return to that, but we'll go ahead.
Well, the last point I wanted to make was that with, if you're talking about the patient portal, they've done some studies and found that it's actually more effective to talk. Like if you're going to educate your patients about a patient portal, it's more effective to talk to them at checkout rather than checking in, because at that point they've already met with the doctor, and then it's more real. Like, yeah, okay, I want to see what this visit is all about and get a copy of it, get their hands on it. So patients tend to be more willing to either sign up or give whatever information is needed in order to get them involved in the patient portal. So just a small tip.
That makes a lot of sense, because obviously people going in to see the doctor are going to be a little preoccupied, even if it's just a checkup or something, whereas when they're coming out they can pay more attention to that sort of information. We've also heard from experts who recommend just small things like having some posters up in the office just to help people be aware that they have this functionality that they can access. And as a final follow-up there, Joy, if in terms of the technical side of this, the EHR is required to include a patient portal to be certified for stage 2. Isn't that correct?
I believe so. I think that patient engagement is required. I don't know of any other way to do that than through a patient portal. So I would say, yeah, by default. I mean, if you do a search for the word patient portal in the stage 2 EHR toolkit, it doesn't exist. But health information exchange and patient engagement is everywhere. And I would imagine that's how, that's one of the main ways of doing it, is through the portal.
So we've talked before about clinical quality measures. How are they going to change in stage 2? You said they've really sort of changed the structure of them a little bit.
They certainly have. In stage 1, clinical quality measures was included as part of a core objective, and they only required that EPs report on 3. So they could choose the 3 core, they could choose the 3 alternative, and if none of those suited them, they can choose from the remainder of a total of 44. In stage 2, they've taken them out as a core measure. So, and now they've increased the number of measures that EPs need to report on. So they now need to report on 9. And of those 9, the requirement is that they need to cover at least 3 of the 6 domains that they've identified, essentially to ensure diversity. So to give you an idea of what those domains are, they're patient and family engagement, patient safety, care coordination, population and public health, efficient use of healthcare resources, and clinical processes and effectiveness. So they have set out 2 different curated lists, one of 9 clinical quality measures specifically for adults, and then the other 9 for pediatric. And then if those don't suit your specialty or your practice, then the total number of CQMs is 64 you can choose from. So you can kind of pick and choose which ones you want from that total list, but you just need to make sure that it covers 3 of those 6 domains. So, there's plenty to think about there. And then lastly, you will need to report them electronically. So they have an electronic or an EHR Medicare incentive pilot program that in 2013 people can use that electronic pilot, the reporting pilot, to kind of get used to it. And then in 2014 and beyond, it's going to be required. So one thing to keep in mind is check with your EHR vendor to make sure that it is programmed accurately to capture all the information for each measure that you have decided to report on. Because each one, it's essentially going to be either an HTML, an Excel format, or as a value set. But the EHR needs to be able to have the functionality and each specification set for each measure. So that is a great conversation to have with your vendor to make sure. And then actually, while we're on that, if you're talking to your EHR vendor, make sure that they are certified for stage 2. Not all EHR vendors are certified for stage 2 at the moment, so make sure that you ask them, what's their timeline for certification, and that they will have the capability and functionality to be able to meet the requirements by the time it's time for you guys to start reporting and testing and gathering all that data.
So let's talk about lab and radiology orders then. What's new there?
Right, so I briefly mentioned that earlier. We were talking about the CPOE requirements. So for stage 2, you're going to need 30% of both lab and radiology orders to be ordered through the EHR. So that's going to mean new workflows. That's going to mean people are going to have to you need to, one, make sure that your EHR is integrated or interfaces with a lab company or a radiology company to make sure that you can both push information and pull information back. That's what you want to be able to create the order within the EHR and then also receive the test results or lab results from there, so in a structured way. So if you have not integrated yet with a lab or a radiology company, when you're looking into that, talk to your EHR vendor and make sure that you're looking for specifically two-way interfaces that have that push and the pull. So one thing to think about is if it's electronically ordered, the CPOE, physicians may be the ones that are placing the orders. Historically, that's something that staff do. So making sure that everyone is trained and knows how to use and create the orders, that's really important. And then lastly, I wanted to mention this is something that I think everyone should use no matter what template, and it's templating your orders. So you can create order sets within your EHR. So for example, if you see people with an annual exam, maybe that includes an order for an ECG, a bone density test, and maybe a blood panel. You can add all those to an order set, and then when you're in your template with your patient, seeing them for their visit, with one click, you would be able to order all 3 of those at the same time. So finding ways to be able to make efficient use of your time and also meet the requirements is something that's going to be really important.
What do providers need to remember about medication reconciliation?
So for 50% of patients that are transferred into your care, you're going to need to do a medication reconciliation. And the point of that is to reduce medication errors that are common among patients who use multiple pharmacies or patients that have multiple disorders or diseases or multiple healthcare providers. And so what we're trying to do is capture a complete and accurate list of the medications that a patient is taking, and including non-prescription and alternative medications, and compare that list with the documentation in the patient's medical record during their visit. So essentially, medication reconciliation is the process of avoiding inconsistencies across transitions in care by reviewing the patient's routine and regimen at the time that they were admitted and transferred, and then comparing it with the regimen that's being considered for their new one. So one way to do this is by looking at SureScripts or your EHR module within your, the e-prescribing module within your EHR. That's a history. Looking at a patient's history can help with medication reconciliation. But just make sure that your staff, everyone needs to ask patients about their medications, and importantly capture that in a structured field. So not just free text.
How can providers succeed with preventive care reminders?
Well, so this one is important. Now think of this one as an opportunity to reach out and engage with patients. So with preventive care reminders, you can essentially create custom reports and then use the recall and alert functionalities in your EHR to make this process simpler. So maybe you're looking for patients that are over the age of 65 or patients that are under the age of 5 years old, and those are the ones that, at least in stage 1, we were capturing that they were due for an annual visit or whatever their checkup is. So providers need to use their EHRs to identify and provide reminders for preventive and follow-up care for more than 10% of patients with 2 or more office visits in the previous 2 years. So you want to be able to automate those things. So if you don't know how to do that, that is something that you need to make sure that your EHR has the functionality to identify patients that are due for preventive care. They probably do. You need to just look in your reporting section of your EHR, and then your EHR should also be able to identify gaps of care at the clinical decision support level, and then should also be able to automate alerts to the patients. So last thing, it's important to document how patients want the reminders sent to them. So educate staff, what patient reminders involved. Make sure that if they want to, that you collect the patient emails so that you don't have to spend the time with somebody on the phone and calling. If their preferred method is email, it's many patients it is. Make sure that the staff is collecting those emails, and establish a workflow and assign responsibilities of who's creating the list, who's sending out the reminder, and who's following up and making sure that those patients have followed up with it.
And obviously, HIPAA considerations wouldn't apply to these emails because they're simply reminders to come in for care. So there's no PHI in those messages.
That's correct. But, you could be sending out those through secure messaging, through the EHR, or through the patient portal, and that might be an opportunity to attack a couple of the different requirements in one go. You'd have, you've got your patient engagement, you've got your preventive care reminders, and then if they respond to you, you've met that 5%, hopefully, of them, engaging.
So, stage 2 is coming. What should providers be doing to get ready right now?
So, first things first, know your objectives. There is a great resource, the EHR Stage 2 toolkit provided by CMS. It's something like 80 pages long, but also very well organized, and it has all links to each measure, objective, their specification, and what's required. So familiarize yourself with that. Now is a good time to start selecting your clinical quality measures, which ones you're going to be reporting on. I would talk to the EHR vendor and make sure that they have the ability and capability of reporting on the CQMs that you select. If you are participating in the Medicaid EHR incentive program, some states have 1 or 2 slightly different requirements. So I would make sure that if you are participating in that program, make sure you check with the state. In the next slide, I'll be providing contact information to each state's website so that you can see, if you have questions or want to look at what the requirements are, you can check that out. And then this one's really important. Review your history. If you are checking out your meaningful use dashboard on a regular basis, looking at it, potentially daily, and seeing where you stand, that is really important in knowing how do you improve if you don't know what you need to improve on. So looking at your reports and seeing, okay, maybe you think that you're doing something correctly, but you're missing a click here or there and it's not capturing it the way that it should. That is something that is really important. And then talking to your EHR vendor for a number of reasons, but one very important one to make sure that they're certified for stage 2. And then lastly, I would say take a technology inventory. Since this one is really, the stage 2 is required, all this health information exchange, making sure that all these systems are talking to each other. Make sure that you have up-to-date information about, what your technology stance is. If you need to upgrade, now might be the time. And I might want to add to this list, maybe get your IT guy some pizza. He's probably, the IT department is going to be working their tail off, so I hear that they like pizza to keep up.
And it sounds like really coordinating with the EHR vendor as well is a key part of that.
Absolutely. Yeah, so there are plenty of things to do. Just start with one and, see how you go.
Well, the good news is there's still time to get ready. Let's look at some of these resources that you were talking about before. Tell us about how these can help people.
Sure. The Stage 2 Toolkit, that's great. That one goes through every single objective. It looks at specifically the changes between Stage 1 and Stage 2. So if you have specific questions and are curious about, the details, they provide a really great overview, and they also provide a really great way that you can just go in and kind of get all the information that you need. They have information on the clinical quality measures, how to get the specifications, and then they have the links to different areas on the CMS website that provides more up-to-date information. So I just say that that's a really good thing to keep, on your either bookmarked in your computer so you can go back on a regular basis. And then for those folks that are participating in the Medicaid EHR incentive program, that's the website where you can find your state's contact information, their website, and feel free to ask them if there's any requirements that differ from the Medicare EHR incentive program. They're going to be the authority on what's needed.
And to remind folks, we will be sending out a copy of the slides, so you'll be able to get the hyperlinks there. It's time for questions, but we might leave up these resources for just another minute in case anyone's trying to copy them down. Before we get into the questions, we've already got quite a few of them. I just want to remind folks that we'll get to as many questions as we can. If we run out of time, we'll answer all of the questions in the written responses. Also, there's occasions where people ask very detailed or technical questions, and sometimes it's better to address those questions in the follow-up. So I want to leave that as an option for Joy as well. Joy is very knowledgeable, but sometimes it helps to point people to other resources. So we'll see if there are any particularly tricky questions. Let's begin with the questions. Are you ready, Joy?
Yes, sir.
All right. So here's the first one. If Stage 2 requires that the CQMs be reported electronically, how will that happen? Many states do not have an HIE running, so how will the CQMs transmit?
So the CMS has right now an eCQM EHR reporting pilot program that they've started. So if you were to go to that Stage 2 toolkit and go down, there's a whole section on the electronic reporting of the CQMs, and it will tell you how you can participate. So if you want to sign up for that and get started and learn how the system works, or at least familiarize yourself with it, you can do that. And or you can look at, they provide the specifications that are required in order to electronically report, and so you can give that information to either your EHR vendor and do that. There's also, we spoke about this in the clinical quality measure webinar, there was a great resource where you can report your CQMs through them. Brian, I'm going to have to look that up again. But yeah, there's a company that is, well, it's not a company, it's put out by CMS that they are reporting if they are helping people extract the CQM data and then reporting it on their behalf electronically to CMS. So let me see if I can find that real quick.
Well, we'll follow up and provide that resource.
Okay.
Let's move on to another question. And remember, to our audience, you can ask questions of our presenter by typing them into your chat area. Here we've got a great question about transition. So here, I'll just shoot it at you. Some providers in the organization of this person are in stage 1, while others are going into stage 2. How do we align the technology to allow for both stages? For example, for stage 1, we called it gender. For stage 2, it's called sex. How do we allow for attestation for some providers for stage 1 while allowing others in the organization to attest for stage 2 if the terms don't align?
Wow, that's a good question. I would talk to the EHR vendor. I think that they would have to help you out with that one. I mean, because if they were certified for stage 1, I don't think that they can, and you've got the upgrade or you've updated your software so that, does it say that now that the term for gender is sex within the EHR? That's a really good question. I would become really good friends with your EHR vendor and ask them.
There has to be a presumption of backwards compatibility here as well, but I'm sure
I would think so.
I'm sure that's
another thing to think. Well, another thing to think about is that I think that starting this year you can batch report your providers. So it used to be that all individual EPs had to attest separately, and then now within a practice you can submit multiple at the same time. So I don't know if they have gotten savvy and sophisticated enough to be able to report a batch of providers that are also reporting different stages. That would be interesting. Well, I'll find that out.
Let's move on to another question. Many physicians are distressed about creating opportunities to get to the 5% threshold for patient portal engagement, made even worse in low-income areas where patients have limited access. Do you have any recommendations on how physicians can promote the portal, such as encouraging children to get vaccination records via the portal, etc.?
I guess if the issue is that the patients don't have access to the internet or to the portal when they're at home, maybe one way to do it would be through a kiosk. If it's something that they can access within your practice, it's possible that you could engage with your patients as by providing a service for them to be able to come in and check their record. I don't know. That's
a great idea. That's a great suggestion. That 5% threshold, it's very low. So they're obviously, it seems to me that they understand that, this is going to take time for people to get into the habit of doing this. But 5% is still a very low number, it seems to me.
I agree. And I mean, when you're talking about people with, lower, or the patients not having as many resources, I'm not sure you would want to send them to the, public library to use their computers. I don't think that you want to be, I'm thinking that a kiosk would be a great opportunity. And you could serve as a better resource for those patients and hopefully get them in your practice more.
And I think, for in areas with low digital access, that's a special problem. But I think for most people, a lot of it is really going to be about thinking through how it's a priority. How can they reach out to patients and literally engage with patients who are likely to respond?
Right. Yeah, and I think you make a good point. Starting with 5%, test out what works. Try a bunch of different things, and whichever one works, follow that one. And then I'm sure that a year from now, that 5% is going to go up.
But the first step is really to think about it and make it a priority in your interactions with patients. Let's move on to another question. Is it true that CQMs can be reported in 2014 via attestation if the eligible professional is in year 1 of meaningful use?
Yes. Haha. Yes, it is.
The easy answer.
That's part of the yeah. That's part of that EHR pilot. So they are testing it now. If you want to participate in it, there's information on that toolkit on how to do so. And so yeah, so they really want people to go in that direction. And think some people are going to be reporting stage 1, you know, as far out as 2015. So they're making that requirement for electronic reporting of CQMs in 2014. So it doesn't matter what stage you're in, you're going to be reporting electronically soon.
All right, let's ask another question then. If a doctor moves and the new location is unable to obtain the same menu items or QM items, what should we do? And if it means we can't attest for 365 days but can pick back up in 2014 for 90 days, would it be 90 days with stage 1, year 2? Or will we jump to stage 2? It's kind of, let me know if you want me to repeat that, Joy. There's kind of a couple different questions in there.
Yeah, no, I think I get it. It sounds like it depends on when they moved and how much information. So is the reason why you can't report on the same quality measures and menu objectives because your EHR has changed, or is it because your patient population has changed and now, you know, what was applicable to you in your practice before is no longer applicable? I think that might, you know, change the question or the answer at least. But as far as if you wanted if it made sense to wait until 2014 so that you could just report the 90-day period, maybe it might be easier to do that. If you're, I mean, moving is stressful no matter where you're doing it or from where to where. So I imagine that catching up and catching all of the changes and making sure that everything is in place so that you can capture all the data required and, you know, do a great job making sure that you're hitting your targets. Maybe you spend the rest of this year making sure that your structure is set up, and then next year you can report the 90 days. And that, you're right, it would be stage 1, year 2.
Here's another question for you, Joy. I'm not sure I understand it entirely, but let me just ask it. We have read that a nurse or CMA may place the order for the physician. Is that true?
I would have to confirm. I believe it is possible. I think that it must be certain people with whatever their permissions are within the EHR, and there are requirements to who's allowed to have whatever those permissions are. I would need to double check exactly what that is, but I want to say that it's folks that have an NPI number. At least I know that folks that are able to have an NPI number are able to order prescriptions, nobody else. So as far as labs and radiology orders, I would imagine that nurses and other people in other roles would be able to do it, but let me confirm in the follow-up.
All right, let's move on to another question then. We started participating in 2011 in meaningful use. On our reports it says, report ambulatory CQMs to CMS, and it has a green check mark. Green check mark means good, and the info is being sent to CMS. Does this mean we are participating in the EHR pilot?
Where is that check mark coming from? Is it something that's within your EHR, or is it something from elsewhere? What did she, can you repeat that first part of the question?
She says in the meaningful use reports, it says there's an entry that says report, yeah, in the EHR, report ambulatory CQMs to CMS. and it has a green check mark by it.
You know, I would not trust that that is entirely, like, that they have been reported and done. I would check with your EHR vendor to just ensure and double check that that information is transferred, because it may just be that they have captured the information and the data, but it doesn't necessarily mean that they've transferred it and reported it. So I would do a double check.
Do a little deeper digging there and find out for sure that that information is being transmitted.
Because you certainly don't want to just say, oh, we got a green check mark, we're all good.
Right.
Yeah.
All right, let's ask another question then. Does medication reconciliation include dosages? As a specialist, we aren't concerned with the dosage, but rather the drug.
Right. I would imagine that it does include the dosage. You should have, you know, your EHR should have that interaction check. So I would imagine that if the dosages are, you know, too high, or that there's, you know, a higher dosage would cause an interaction with some other medication, that it would capture that. I would learn how to use the that clinical decision support tool within the e-prescribing, and making sure that, you know, you get, like, okay, these different medications are interacting or whatever. So,
and of course, part of what's tricky about all of this is that the EHRs, although they're built around these core requirements, can be different in various ways. So it's hard to sometimes it's hard to give a universal answer to some of these questions.
Yeah, I agree. I would include the dosage personally. I think that it's something to keep track of. Just to, I mean, maybe just making sure that it's, you know, not too high, or, yeah, I mean, one, knowing what the medications are, making sure that they're not interacting, but I imagine that the dosage is a very important part, especially, you know, if you're 1 decimal place off, then that could be a really big deal for someone. So, yeah.
So that's valuable data to report, or record at least. Let's move on to the next question, and it's related to medication reconciliation. The question is, what defines transferred to your care? As a specialist, it's actually another specialist, this is from another person, but also a specialist, and they have patients transferred to them, or I'm sorry, they have patients referred to them. Does this constitute them being transferred to their care?
Yes, it does. So that means for the specialists that are have a ton of referrals, yeah, that 50% is going to be based on a lot. You know, your patient population is going to be higher. So yeah, anyone that comes from a different setting of care into your care, 50% of those patients need to have the medication reconciliation. So what you can do, steps that you can perform, you know, develop a list of their medications, of their current medications, develop a list of medications to be prescribed, compare the medications on those 2 lists, and then use your clinical decision support tool to help, you know, base the comparison to see if there's any interactions, and then communicate that new list to the appropriate caregivers and then also to the patient. So making sure that the patient knows what their status is with their medication too, you know, keeping them informed.
Here's a question about state registries. Who can I reach out to regarding state registries to see if I need to even be concerned about reporting? And if the registry is not up, can I exempt myself?
Are you talking about reporting quality measures? I would think that, well, so we did that. We did a webinar recently on the PQRS, and there's a PQRS qualified registries. I'm not sure that they're the same as the clinical quality measures registry. So that's a very good question. but each state should have a registry, so I don't know that you can, if they don't have one, if you can just opt out. I would imagine that at least until 2004, I mean, because especially by the time you're reporting stage 2, it's going to be 2014 or beyond. So if they don't have a registry now, they probably will very soon, because it's going to be a requirement, and then you probably will not be able to opt out.
Let's ask another question. This audience member is concerned about their patient reminders. She says if the denominator is there's some abbreviations in here. If the denominator is PTS, seen 2x in the last 2 years, but the numerator, patients, there we go. Okay, sorry. It took me a minute to try to interpret that. If the denominator is patients seen twice in the last 2 years, but the numerator is for patients seen during the reporting time, wouldn't the reporting time be 3 months? Do you see what they're saying? They go on to say that would mean all those patients would have to have a reminder during our 3-month reporting period, which is a short time, or will it count if they had a reminder anytime in the last 2 years?
So the way that it reads, EPs must provide reminders for preventative and follow-up care for more than 10% of patients with 2 or more visits in the previous 2 years. So I would imagine that that is a function of the meaningful use dashboard is tracking that information. So it's probably an algorithm that's created sort of like the CQMs, of just like as it's tracking specific data entries, and one of those would be when they had an appointment and when a reminder was sent, etc. So I think that what you're saying is the patient reporting period would be the 90 days, but it would be looking at the previous 2-year history of that patient and how often that they came in. So that would be part of the calculation of the denominator. But yeah, that one is a little bit, it's tricky in concept. So if you have questions about how that is calculated, I mean, maybe we can talk to an EHR vendor and find out, the nitty-gritty, the details on what it is. But yeah, both are important. Both the 90-day reporting period, if we're talking about 2014, and the patient visits within the last 2 years. Does that make sense, Brian?
That does make sense. Here we have a couple of comments that are useful, I think. One of our guests mentions that most EHR vendors are going to use mappings to handle changes such as sex, the conversion from gender to sex in the terminology. Okay. So that sort of, I think, alludes to the backwards compatibility issue we were discussing during that part of the presentation. So that would be an area to, again, probably talk to your EHR vendor and get into the details of how they're handling that technically.
Sure.
And here's another comment. It says that CQM e-reporting can sometimes also be fulfilled by use of the PQRS e-reporting program. Could you comment on that, Joy?
Sure. Yeah, so there is the way that what it's called is that, so PQRS is capturing data on other quality measures, the physician care reporting system, the quality reporting system, and although there are a lot more measures that are included as part of PQRS, the 44 that are included in stage 1 and the 64 that are included in stage 2, but right now, since we're just tracking stage 1, you can use the PQRS electronic reporting module, or it's called the PQRS EHR Medicare Incentive Program reporting module, and to report both your PQRS measures and your CQM measures. So if you are looking to get a double whammy, that would be your way to go. And there are EHR data submission vendors that can help you through that, because a lot of the reporting requirements are slightly different between PQRS and CQM. So there is a list of EHR data submission vendors that can help kind of get that information for you and help you along with that reporting pilot too. So that is a great option for people if you're also doing if you're aligning your PQRS with your CQMs.
We don't have a lot of time left. We've got time for maybe one or two quick questions, but I have to say we haven't gotten to everything. We've got a great group today. There's some interesting comments in here that I won't read right now due to the time limit, but there is a lot of concern among providers clearly about the patient engagement piece of it and the HIE piece of it, that that it may be difficult to get patients to engage, and that all of the pieces of the HIE part of things are not necessarily in place. So I just wanted to mention that there's been a number of comments along those lines, and we hear that out in the world anyway. Maybe you'd like to weigh in on that, Joy.
Sure. I agree with you on the HIE thing. Other than the continuity of care documents and then actual interfaces between specific companies, like that is certainly a struggle and a challenge that people have, because all the pieces are not yet in place for a number of different reasons. One is like, who pays for it? That's always a question. Who's going to pay for us to create an interface? That's a common topic that comes up. I've seen recently, actually just yesterday, there was an article that came out about there's a couple of free HIEs that are out there, and they're trying to help people transmit data, so that kind of takes away that problem. But yeah, it's not set up. That is definitely sort of the next phase. And as far as patient engagement, portals, they have apparently only 20 to 25% of eligible professionals will have patient portals by the end of this year. So that is something that it's growing, it's important, it's like something that there's a big push for, but there has not been quite that much adoption of yet, because I think people are still trying to understand, how to incorporate it into their business model. How do they actually engage with patients? Do you just buy a software system, and does that qualify as engaging with patients? Like, the integration of those things can be tricky. So I think that both of those are good topics for future lunch and learns, to be honest.
We might take your hint on that one. I'm afraid we're out of time, but we did get a lot of questions, and I want to remind our audience that we're going to go ahead and answer those questions in the written follow-up. They're really great, insightful questions, so I want to thank all of our audience members for their questions. I also want to thank you, Joy, for joining us today. These are always some of our most informative and lively sessions.
It's my pleasure. Thank you very much for having me.
If you would like to contact Joy directly, you can email her at j.rios, R-I-O-S, at formatapproved.com. I'd also like to thank our attendees again. Remember that all registered attendees of this event will receive an email with links to both the slides and the recorded version of the session. Do you need training in meaningful use? Register for Format Approved's new Certified Meaningful Use Professional course. The course covers the requirements for both Stage 1 and Stage 2 of meaningful use for both eligible professionals and eligible hospitals on the Medicare and Medicaid incentive programs, along with clinical quality measures, HIPAA considerations, and more. Visit the URL on your screen. That's www.formatapproved.com/education/courses_cmup.html to learn more about the course or to register. You can learn more about our other training offerings at formedtraining.com. Visit formetapproved.com to learn more about our upcoming learning lunches. The Learning Lunch button will take you to our entire slate of upcoming webinars. Our next Learning Lunch will air July 30th, and will cover the subject of tools for transition to ICD-10. Keep an eye on your email box and our homepage for other upcoming topics, and thank you again for joining us today.